I'm Dr. David Bernstein. Welcome back to our series, 25 Tips for Working with Modes. Now, over the last few videos, we've talked about how to investigate people's long-standing dysfunctional patterns, and how to explain those patterns to them, either by telling a story about their lives, using modes as a central concept, or by making a visual representation of a person's modes in the form of a mode map. Now, this is a series about working with modes, and so that's naturally what we've been focusing on. But in schema therapy, there's also a related concept, which is early maladaptive schemas. And so it may have occurred to you at some point during this series, hey, when should I work with modes and when should I work with schemas? And that brings us to today's topic, choose it. Now, some schema therapists work primarily with early maladaptive schemas. And maybe they use a little bit of modes from time to time, but the main focus is on schemas. And some schema therapists work primarily or even exclusively with modes. So this does raise a question, why? When should you choose to work with schemas? When to work with modes? Or could you work with both? So first of all, let's zoom in a little bit about, what exactly are schemas and what exactly are modes and what's the similarities and what are the differences between the two of them? Because once we figure that out, then the answer to this question of whether you should use one or the other or both becomes clearer. Now, early maladaptive schemas, were defined by Jeffrey Young as broad, pervasive themes or patterns that run through someone's life. Like, for example, an abandonment schema. That's a kind of long-term theme or pattern where the person expects to be abandoned, especially when they start to get close to somebody. Now, these themes or patterns, according to Young, consist of thoughts and emotions and bodily sensations and memories, and they start early in somebody's life, and they're elaborated over the course of a lifetime, and they are dysfunctional to a significant degree. Okay, so simply put, these are long-standing, self-defeating patterns. Okay. Now, early maladaptive schemas, this was the original concept that Jeffrey Young developed, and for a while that concept seemed to work pretty well, and he would just, in schema therapy in those days, people would mainly use early maladaptive schemas, but they would also then talk about how people coped with those schemas, the three broad coping styles of avoiding, overcompensating, or surrendering to schemas. So that combination of the schema concept and the concept of broad dysfunctional coping styles, and then the more specific ways in which people use different kinds of coping responses within each of those broad styles, seem to be sufficient for a fair number of patients. But the problem was that these concepts didn't really seem to be so useful for working with more severe patients. And part of the reason for that, was that these patients seemed to switch rapidly from one extreme emotional state to another. And therefore, Young came up with the concept of modes in order to help work with more severe patients. Okay, now, so far so good. But actually, schemas and modes are related concepts, so let's take a look at them. Schemas are trait-like entities. They are long-standing themes or patterns, right? They're kind of chronic tendencies in a person to view themselves in certain ways, or view their relationships with other people in certain ways. Whereas modes are states. They're things that occur in the present moment. Okay, so there are emotional reactions that occur when something triggers a person in a particular situation. So on the surface, these things look rather different, and yet here's how they're related. Schemas even though their long-term patterns or themes are not active all the time. You could say that they're latent. And then when those schemas are triggered at a particular moment, what you get are modes. And so one way to think about, modes is that modes are the active state of schemas. And let me give you an example. Okay, so here's an image from our iModes tool of the abandoned child mode. Now, imagine that somebody's in a particular situation. Maybe a person is anticipating that the person that they're starting to get close to is suddenly going to leave them, and they kind of are overwhelmed with feelings of loss and dread and despair. And this is what is referred to as an abandoned child mode. Well, here's how this mode is related to schemas, because another way to think about this is that this is a moment when somebody's abandonment schema has been triggered and the person is giving into it. It's giving into it, or quote, surrendering to it in schema therapy language. And, as a result, is just feeling terrible, overwhelmed with these kinds of painful feelings. Okay, so here we have an abandoned child mode, which represents a state, something that somebody's feeling at a particular moment. But you can see how it's related to this long-term theme or pattern of abandonment. And so in a certain way, especially when it comes to modes that involve vulnerable emotions, you can readily see the relationship. It's almost like, what's going on with schemas is kind of like the macro level. It's kind of like the big picture of somebody's life. Looking back over the course of somebody's life, we see this repeating theme or pattern of abandonment. Whereas the schema is kind of the micro level. It's kind of like zooming in to a particular moment when somebody is feeling in a way when that schema is activated. Okay, now so far so good. In that sense, it almost looks like we could use schemas and modes as interchangeable concepts. But let's go a step further. What about this mode? Okay, this is the image of the detached protector mode. What's somebody feeling when they're in this mode? Well, they're feeling nothing. They're feeling numb. They're cut off from their emotions. Okay. So here we have a mode, but how is it related to schemas? Well, presumably, because this mode involves a certain kind of coping, an avoidant form of coping, it's reacting to something. And, presumably it is reacting to some kind of activation of a schema. Now, if you take a look at the image, what you see on the right are, somebody's feet, right? So there's a little child, perhaps, that's crouched behind this wall, hiding. And, that sort of implies the fact that, there is a schema in there somewhere that's been triggered. And the person copes with it by, detaching from their feelings. And so even here you could say that somewhere in the mix is, let's say, an abandoned child mode, if that happens to, an abandonment schema, if that happens to be the schema that got triggered, but that due to the overwhelming effect of the person's avoidant coping, this mode is dominated by coping. Now, this helps to explain why sometimes we need to use modes. Because schemas are a fine concept when people are able to be in touch with their vulnerability, when they can feel their vulnerable emotions and then talk about what those themes or patterns are. But what happens when the so-called coping modes, or what we've called the bodyguard modes, dominate a person's functioning? What happens at those moments when a person detaches from their feelings? And, at that point, it's sort of fruitless to try to talk with them about their schemas because they're not in touch with, their emotional vulnerability. So instead, we need to focus on their modes. And so that was the original reason why Jung came up with the mode concept, because he noticed that there were certain blockages or stuck points in treatment. And in order to, get over those stuck points, you needed to be able to work with the mode that was front and center and dominating the person's consciousness. You know, that, as we've talked about before, when modes are activated, they dominate how people think and how they feel and how they cope and how they perceive things. Okay, so then one way to think about it is this, that, you know, let's say you're a schema therapist and you feel you like working with schemas. Well, then, you know, you can still predominantly work with schemas, but it's very useful to have a kind of vocabulary of modes when there are stuck points in treatment, when the patient is stuck in terms of, let's say, the therapy or the therapy relationship, or also when they're stuck in their lives, you know, when they, you know, when there's some modes that keep getting in the way. Okay, so, you know, you may choose to predominantly work with schemas and then just bring in modes selectively at those points of stuckness. Now here's another way to think about it. What about patients who are almost always stuck? What about patients who, you know, in the therapy you notice that the therapy is just dominated by either rapid fluctuations from mode to mode, or, you know, they are stuck in a particular mode, like let's say patients who are just so avoidant that, you know, they're just out of touch with their emotions all the time. Okay, in these kinds of cases, what you want to be doing is focusing either predominantly or exclusively on modes. Now, so who are these people who are stuck most of the time or all of the time? Well, they're less healthy patients. They're patients who have, you know, less healthy adult mode capacity. They're more severe patients. And so what you can see in this simple diagram is that for healthier patients, if you'd like, you can, you know, primarily focus on early maladaptive schemas, talk with people about their schemas, and just bring in modes selectively at those moments of stuckness when you need them. But for less healthy patients, more severe patients, we need to focus on modes. Now, some people like to combine these two things, and that's fine in some cases. If you're only using modes selectively, then your main vocabulary, if you will, is the vocabulary of schemas. Or for more severe patients, just focus on modes. One thing that I don't recommend is, you know, using both languages extensively with the patient, you know, so, you know, you're going back and forth, you know, schemas here and modes there, and lots of, you know, having to take a lot of time to explain to people what schemas are and a lot of time to explain what modes are. You know, that I don't recommend. I think that that can be confusing for patients. So what I would suggest, if you're kind of more of a person who's comfortable working with schemas, for healthier patients, go ahead and use them, bring in modes selectively. If you work with more severe patients, I suggest you work exclusively with modes, okay? And some people just use the mode language all the time. And how do you do that? Well, when talking about people's, you know, let's say vulnerable modes, you can then, if you will, you know, use some of that schema language, but without really labeling it as a schema. You know, so you can say, let's say somebody who has a, you know, failure schema, you can talk about, you know, the side of you that's feeling like a failure right now. Okay, so you can kind of translate those schema terms into mode terms for some of those patients. Okay, so now that we understand more of what schemas and modes are, it becomes much easier then to make some decisions about when to use schemas, when to use modes, and when is it useful to use both. Okay, now, next time we're going to continue with our theme of, you know, dysfunctional patterns, and we're going to talk about some of the things that people do to perpetuate those dysfunctional patterns and what you can do about it. And that will bring us to our next video, Don't Feed It. And finally, please come to our website, www.imodes.com, and take a look at our image-based therapy tools. Have a great week, and see you next time.